Bismillahirrahmanirrahim. Now we will discuss about cerebellar disease. Cerebellar disease. Cerebellar disease results when there is lesion in the cerebellar cortex and one or more of the deep cerebellar nuclei. So lesion is in the cerebellar cortex and one or more of the deep cerebellar nuclei. In cerebellar disease, there is no paralysis and no sensory loss. So no paralysis and no sensory loss in patients of cerebellar disease. What are the features? The basic feature is ataxia. Ataxia is incoordinate movement due to error in the range, distance and direction of the movement. So there is error in the range, direction and force of the movement, which results into ataxia. There is asymmetria. There is no synergism between agonists and antagonists. So no synergism between agonists and antagonists. There is dysmetria, inability to control the range of movement, inability to control the range or extent of movement. The patient wants to touch this object. The hand may overshoot or undershoot. A patient of this disease wants to pick or touch some object. The hand may go beyond the object or it may undershoot. This is called dysmetria. And one feature of dysmetria is past pointing. That is, the hand overshoots the intended mark. The hand overshoots the intended object or mark. This is called past pointing. Next feature is adiaglucokinesia or dysdiaglucokinesia. Adiaglucokinesia or dysdiaglucokinesia. Inability to perform rapid, alternate, opposite movements. Inability to perform rapid, alternate, opposite movements, such as supination and pronation. Supination and promotion. So inability to perform rapid, alternate, opposite movements, such as rapid supination and pronation. This is adiaglucokinesia or dysdiaglucokinesia. Next feature is gait is drunken, staggering gait. So drunken gait or staggering gait. Patient walks on a broad base. Patient can't walk on a straight line. But walks on a wide base. Staggering gait or drunken gait, patient walks on a wide base. The head is bent towards the affected side. Shoulder on the affected side is lower. So shoulder on the affected side is lower. And head is bent outward towards the affected side. There is a dysarthria or slurred speech. Dysarthria is due to incoordination of muscles of phonation and articulation. It is due to incoordination of muscles of phonation and articulation. This is called dysarthria. Slurred speech. Some of the syllables are spoken loud, some are spoken weak, some syllables are spoken long, some are spoken very short. So this is called slurred speech due to dysarthria, incoordination of muscles of phonation and articulation. So some syllables are spoken loud, some are spoken weak, and some are held for a long time, some are spoken short. There are action tremors or intention tremors. Action tremors or intention tremors. Tremors of the hand appears during action. Tremors of the hand appear during action. The patient wants to pick this object, so as the hand approaches towards the object, tremors appear. Our patient wants to hold a cup of tea, so when he tries to pick up the cup of tea, there are tremors which are called the action tremors or intention tremor. Action tremors or intention tremor. Our next feature is decomposition of compound movements, complex movement. Decomposition of compound movements or complex movement. A person takes bread with curry. The hand is moved towards the bread. A piece of bread is taken, dipped into curry, and then taken into mouth. So this eating of bread with curry is carried out normally, normal person, in a smooth way, and moves towards the bread. A piece of bread is taken, dipped into curry, and then taken into the mouth. So this action involves simultaneous movements at different joints. This action involves simultaneous movements at different joints. So movement of the hand towards the bread, a piece of bread is taken, dipped into the curry, and then taken into the mouth. So this action is carried out at a smooth way. But in this patient, he is not able to carry out actions involving movements at more than one joint. So patient can't perform actions involving movements at more than one joint. He will first move the hand towards bread, then try to take some bread. Tremors appear. So a piece of bread is taken and dipped into curry, and then the hand is moved towards the mouth, right? So the piece of food is not bread is not taken to mouth. It may touch here, right? So these movements can't be carried out which involves movement at more than one joint. There is also rebound phenomenon. The patient is unable to stop a movement abruptly. The patient is not able to stop a movement abruptly. The doctor asks the patient to pull the hand towards himself, and doctor holds the hand of the person. The doctor holds the hand of the person, and the patient tries to pull the arm towards himself. While he is pulling the hand towards himself, the doctor releases the arm, releases the hand, and the hand touches his breast, his chest, or the mouth. So this is called rebound phenomenon, right? The doctor holds the hand of the patient, and patient is asked to pull the arm towards himself. The doctor will release the hand abruptly, and the hand strikes the chest or the face of the person because he is not able to stop a movement abruptly. This is the rebound phenomenon. Next feature of the cerebellar disease is cerebellar nystagmus. Cerebellar nystagmus. Nystagmus is oscillatory rhythmic movement. Oscillatory rhythmic movements of the eyeballs when the person fixates eyes towards one side. When the patient fixates eyes to one side, in the eyeball, in the eyes, oscillatory rhythmic movements appear. This is called cerebellar nystagmus. Nystagmus is more marked when the region is in the vermis and flocculonodular lobe. So it is more marked when the region is in the vermis and flocculonodular lobe. Next feature is hypotonia, atonia. Right? And there is pendular knee jerk. You visit the knee jerk, you strike the patellar tendon with the clinical hammer, the hand, the leg moves like a pendulum. It moves like a pendulum. So pendular knee jerk is present in cerebellar disease. When you visit the knee jerk, there is pendular movement of the leg. So these are the features of the cerebellar disease. There are some cerebellar function tests. Cerebellar function tests. You can diagnose this patient very easily. The patient enters doctor's clinic and you see the patient having a drunken gait, staggering gait. Right? Other tests includes finger test, finger nose test, demonstration of adiabadokinesia, right? Pendular knee jerk, and then patient is asked to asked to walk on a straight line. Right? You can perform Romberg sign, Romberg test. So these are the cerebellar function tests which you can perform. You must have carried this experiment in the laboratory. Right? So this was about the features of the cerebellar disease. Next we'll start discussion on the basal ganglia or basal nuclei. Basal ganglia or basal nuclei. Basal ganglia are the masses of grey matter present in the white matter of each cerebral hemisphere. So masses of grey matter present in the white matter of each cerebral hemisphere. Now these masses of grey matter, these include the caudate nucleus, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. So basal ganglia includes the caudate nucleus, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. So these 5 structures are included in the basal ganglia: the caudate nucleus, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. Caudate is separated from the putamen by the internal capsule. Right? So caudate is separate from putamen by the internal capsule. Caudate and putamen are collectively called as corpus striatum. So caudate and putamen, these are collectively called as corpus striatum. Corpus striatum. Putamen and globus pallidus are collectively called as lentiform nucleus or lenticular nucleus. So putamen and globus pallidus are collectively called as lentiform nucleus or lenticular nucleus. So this is the introduction to the basal ganglia. Basal ganglia form an accessory motor system. Basal ganglia form an accessory motor system which do not function independently. We don't function independently, but with the help of the motor cortex and corticospinal system. These function with the close help of the motor cortex and the corticospinal system. Basal ganglia have got multiple connections. These are multiple connections. In the connection of basal ganglia, two circuits are important: the putamen circuit and the caudate circuit. So in the basal ganglia connections, two circuits are important: the putamen circuit and the caudate circuit. So two circuits are important: the putamen circuit and the caudate circuit. This is the putamen circuit. Fibers arise from the primary motor area, supplementary motor area, and somatosensory area. So fibers arise from primary motor area, premotor area, supplementary motor area, and somatosensory area. So these nerve fibers, after origin from primary, premotor, supplementary motor areas, and somatosensory area, these go to putamen. You see, nerve fibers go to putamen, bypassing the caudate. From putamen, nerve fibers go to the globus pallidus. From putamen, these go to the globus pallidus. From globus pallidus, nerve fibers arise, and these go to the ventro-anterior and ventro-lateral nuclei of thalamus. So these go to ventro-anterior and ventrolateral nuclei of thalamus. And from these thalamic nuclei, nerve fibers arise, and these go to the primary motor area, supplementary motor area, and premotor area. So from these thalamic nuclei, fibers arise, and these go to the primary motor area, premotor area, and supplementary motor area. So this is the main putamen circuit. So nerve fibers arising from the premotor area, premotor area, supplementary motor area, somatosensory area, these go to putamen. From putamen to globus pallidus, and then from globus pallidus to the ventro-anterior and ventrolateral thalamic nuclei. And from here, nerve fibers go to the primary motor, premotor, and supplementary motor area. This is the main putamen circuit. Now there are some additional connections of the putamen circuit. So there are some additional connections of the putamen circuit that from globus pallidus, fibers go to substantia nigra, then to the thalamic nuclei, ventro-anterior and ventral-lateral nuclei, and from here to the cerebral cortex. So additional circuit of connection include that fibers from globus pallidus go to the substantia nigra, then to thalamic nuclei, ventro-anterior, ventral-lateral thalamic nuclei, and then to the cerebral cortex. Other connection is with this main circuit, globus pallidus to subthalamus, globus pallidus to subthalamus, then to thalamic nuclei, and then to the cerebral cortex. Some fibers go to the subthalamus, some fibers go from globus pallidus to subthalamus and then back. So some nerve fibers pass from globus pallidus to subthalamus and then back. So this was about the putamen circuit and some additional connections of the putamen circuit. Now we come to the caudate circuit. This is the caudate circuit. So fibers from the prefrontal cortex, premotor and supplementary motor areas. So fibers from prefrontal cortex, premotor and supplementary motor areas go to the caudate. From caudate to globus pallidus, from caudate to globus pallidus, and from here to the ventro-anterior and ventro-lateral thalamic nuclei, and from thalamic nuclei, nerve fibers go to the prefrontal cortex mainly. Right? So fibers from the prefrontal cortex, premotor and supplementary motor area go to the caudate, from caudate to globus pallidus, and from globus pallidus to the ventro-anterior and ventro-lateral thalamic nuclei. From here go to the prefrontal cortex or cerebral cortex. One thing you must know that in the caudate circuit, no connection with the primary motor area. In the caudate circuit, no connection with the primary motor area, connection with the prefrontal cortex, premotor, supplementary motor area, but no connection with the primary motor area. Right? So this was about the circuits or connections of the basal ganglia. In the basal ganglia, there are certain neurotransmitters, and these neurotransmitters are important in the functions of the basal ganglia. These are important in the function of the basal ganglia. Corticostriate fibers, nerve fibers which pass from cerebral cortex to caudate and putamen. So corticostriate fibers are cholinergic. These release acetylcholine at the nerve endings. So corticostriate fibers which pass from cerebral cortex to caudate and putamen, these release acetylcholine. These fibers are cholinergic. Fibers which pass from substantia nigra to caudate and putamen. So these fibers are nigrostriate fibers. So fibers from substantia nigra to caudate and putamen, which are called nigrostriate fibers, release dopamine at the nerve end. So dopamine is released as neurotransmitter from the nerve fibers which pass from substantia nigra to caudate and putamen. Fibers which pass from corpus striatum, caudate and putamen. Fibers pass from caudate and putamen to substantia nigra and globus pallidus. These release GABA, gamma aminobutyric acid. So nerve fibers which pass from caudate and putamen to globus pallidus and substantia nigra, these secrete GABA, gamma aminobutyric acid. So corticostriate fibers are cholinergic, nigrostriate fibers are dopaminergic, and fibers which pass from caudate and putamen to globus pallidus and substantia nigra, these secrete GABA, gamma aminobutyric acid at the nerve end. Nerve fibers which come from the brainstem to basal nuclei, these may release norepinephrine, serotonin, and enkephalin. So fibers which come from brainstem to the basal ganglia, these release norepinephrine, serotonin, and enkephalin. So don't forget the corticostriate fibers which are cholinergic, nigrostriate fibers which are dopaminergic, and fibers which pass from caudate and putamen to globus pallidus and substantia nigra, these secrete GABA, gamma aminobutyric acid. So this was about the neurotransmitters in the basal ganglia. So we stop here. We will continue next.